Take it away.
Great, thank you. Good afternoon, everyone. Thank you so much for joining our Complementary and Integrative Health Cyber Seminar series. For those who attend regularly, you'll know that this is part of our Query Complementary and Integrative Health Evaluation Center dissemination efforts. As part of this partnership with the Office of Patient-Centered Care and Cultural Transformation, and within that, the Integrative Health Coordinating Center, we offer these bi-monthly CIH cyber seminars, and we're really excited that you can all join us. Today, we have 3 speakers, and I'm going to introduce them. We have Dr. Ursula Kelly, who is a nurse scientist from the Atlanta VA healthcare system in Atlanta, Georgia, and is an associate professor at Emory University's Neil Hodgson Woodruff School of Nursing, also in Atlanta. Dr. Kelly is the principal investigator of the VA HSR&D study of trauma-sensitive yoga for women veterans with PTSD who experienced military sexual trauma, which is what the focus of today's talk is about. Dr. Kelly's research has focused on interpersonal violence against women, specifically the mental and physical effects, barriers, and facilitators to disclosure and treatment seeking related to intimate partner violence and MST, and innovative treatment models for the psychological effects of interpersonal trauma. Her research is theoretically grounded in intersectionality and health inequities and has been conducted primarily with Latinx immigrant women and African American women veterans. We also have Terri Haywood, who is an Air Force veteran and a research health scientist with the Atlanta VA healthcare system. Terri has served as a project manager and coordinator for various multi-site studies focused on interpersonal violence and trauma among women veterans. And then we also have Dr. Belle Zaccari. Dr. Zaccari is a clinical psychologist at the Salem Rural Behavioral Health Clinic at the Portland VA, as well as an assistant professor in psychiatry at Oregon Health and Sciences University. Dr. Zaccari's major research interest is the use of telehealth modalities to deliver complementary and integrative health interventions such as yoga for the treatment of chronic pain and PTSD in veterans. And this is also the focus of her ongoing K-12 research. We will also be joined at the end of this presentation by Allison Whitehead, who is the director of the Integrative Health Coordinating Center for the VA within the Office of Patient-Centered Care. And for most of you who attend regularly, you'll know that Allison likes to provide a 2 to 3 minute reflection on what we just heard in our presentation and how that fits in with current VA programs, practices, and policies throughout the country. So your questions can be posed to both our speakers and as well as Allison at the end. So with that, I'm going to hand it over to Dr. Kelly to begin the presentation. Thank you.
Thank you so much, Ronnie, and thank you for the invitation to share the results of our study with you and with this group. And thank you also to this steadily growing attendee audience. So thank you all so much for being here. So the shorthand name of our study, after you heard that longhand version, is Project Stress Less, and sometimes just PSL, which has been in the works for many years, including feasibility and pilot studies prior to this randomized control trial. As you can see, the Project Stress Less team has included so many people. First and foremost, literally hundreds of women veterans, multiple study staff, students, volunteers, and a robust team of co-investigators from multiple disciplines, including Dr. Zaccari, who's presenting today, and many supporters. I want to specifically acknowledge a few folks who have been involved since the beginning, which was 9 years ago, including David Emerson, who is the founder of Trauma Center, Trauma Sensitive Yoga, which you will hear us refer to as TCTSY throughout this presentation. Dave accepted a cold call from me about studying TCTSY with women veterans in the VA, and now here we are. He also invited the global TCTSY facilitator community to join this call, so welcome to all of you who have come to us from outside of the VA. Stacy Shulman is an Atlanta-based TCTSY facilitator who has provided sessions throughout this entire project and has mentored every subsequent TCTSY facilitator. Also working with me on this project from the very beginning is Dr. Maliga Higgins, a co-investigator and a professor and director at the Emory School of Nursing, who has provided her amazing expertise and endless effort to conduct literally all of the statistical analyses on this project. And of course, I also want to acknowledge several essential sources of support for this study, including the Atlanta VA Trauma Recovery Program leadership and clinicians, the VA Women's Health Research Consortium, including the Women's Health PBRN, who assisted with making this a multi-site study, and of course, my VA HSR&D scientific program officers and VA clinicians in Atlanta and in Portland who provided the psychotherapy interventions and referrals to this study. This study was funded by HSR&D, specifically by the Nursing Research Initiative mechanism, which has been retired. The presenters today are speaking only for ourselves and the women veterans who participated in this study, and we have absolutely no conflicts of interest to disclose. Having said all of that, let me tell you about our plan for today. We'll provide a brief background and the rationale for the study, as well as the original study aims, the study methods, which not surprisingly changed rapidly and dramatically with the COVID-19 pandemic-related shutdowns. We plan to spend the bulk of our time presenting some of our study results, specifically our outcomes of PTSD symptoms, as well as depression-related outcomes, which were actually not part of the original aims. And I'll also talk with you about attrition and treatment completion. I'll highlight a few discussion points and next steps, leaving as much time as possible for audience discussion and Q&A. And with that, I'll turn this over to Ms. Terri Haywood, who served as the project manager on this study and truly brought it to a successful conclusion in the last 2 years. I literally, we could not have done this without Terri. So thank you so much, Terri, and I am going to make you a presenter.
Thank you so much, Dr. Kelly. PTSD is widely used colloquially to describe stress-related disturbances. However, in clinical settings, as well as this project, we use more standardized diagnostic criteria, specifically that of the DSM-5. These criteria, generally speaking, include experiencing or witnessing a significant threat resulting in fear or helplessness. The broad constellation of symptoms include disturbances in cognition, avoidance, and increased arousal following that traumatic event. Some of the hallmark symptoms include sleep disturbances, nightmares, insomnia, hypervigilance, detachment from friends and family, and loss of interest. PTSD rates among military members and veterans are higher than the general population. The majority of these data are from veterans enrolled in VA healthcare systems nationally and obviously include combat-related trauma. As you would imagine, these numbers have been significantly impacted by the Iraq War and the Afghanistan War that occurred over the past 20 years. Although in recent years, women are increasingly serving in combat roles, women veterans with PTSD is still most often related to military sexual trauma. MST is broadly defined by DoD and VA as sexual assault or repeated threatening sexual harassment during military service. Also, data has shown that a history of complex trauma and complex PTSD makes standard treatments less effective. When we're thinking about complex trauma and complex PTSD, we're primarily thinking about the chronicity of the trauma, which in many cases, especially among military members, may include multiple deployments, ongoing sexual harassment in the workplace, or even multiple sexual assaults. Our sample included women veterans currently enrolled in the VA healthcare system in Atlanta or for the second leg of the study in Portland. Why this population? Well, approximately 20% of all women veterans receive their care at the VA. This makes a significant portion of the target population accessible and available for outreach within the VA system. Women veterans in general are expected to increase by 7% by the year 2046. VA is also a leader in developing and providing evidence-based PTSD treatment, specifically prolonged exposure, also known as PE, and cognitive processing therapy, known as CPT, which we used in this trial. While effective, these treatments are less desirable by patients and often result in high dropout rates. PTSD is a complex diagnosis, and while current treatments such as PE and CPT are effective, the process is difficult and can be quite distressing for patients. So, the use of complementary and integrative health interventions in VA has grown significantly with increased popularity and the expansion of whole health. This study was designed to address the gap in effective treatment options and the increased use of yoga in the clinical setting for wellness and PTSD. Our aims for this RCT were to evaluate the effectiveness of trauma-sensitive Hatha yoga compared to CPT, which is currently the gold standard for PTSD treatment. Specifically, aim one, we were examining the effectiveness in reducing symptoms of PTSD, chronic pain, and insomnia. And for aim two, we examined the effectiveness in treatment improving quality of life and social functioning. Aim three, we examined the impact on biological and psychophysiological markers. Today, we'll be presenting results related to PTSD as well as depression. As mentioned, we enrolled women veterans with current PTSD related to MST. They were either enrolled at Atlanta or Portland healthcare systems. In Atlanta, our first participants were enrolled in March 2016 through February 2020, right at the beginning of COVID. So for a total of 9 cohorts in Atlanta. And in Portland, we started recruiting in February 2020, right before COVID. And as a result, we had to halt enrollment. So we enrolled 1 cohort in Portland, and we were able to resume enrollment virtually in May of 2020. And Dr. Zaccari will speak more to the pivot that resulted from COVID-19. So in Portland, we ended up with a total participants of 28. In Atlanta, it was 103. So data collection included self-report and clinician-administered assessments, as well as biomeasures that will be discussed in this next slide. So our time points were baseline, mid-intervention, which was 5 weeks for TCTSY, and for CPT, that was 6 weeks. 2 weeks post-intervention, which was after 10 weeks of treatment for TCTSY, and 12 weeks of treatment for CPT. And finally, our final assessment and follow-up was 3 months post-intervention. So our intervention included, as mentioned, trauma-centered, trauma-sensitive yoga and cognitive processing therapy. So assessments for all time points included PTSD, sleep and pain, mental health and quality of life, and various psychophysiological measures, which included ECGs, heart rate variability, dark startle, which was done in Atlanta, and blood draws to assess cytokine levels. And that was done via blood draw in Atlanta. And when we did the COVID pivot, we did finger pricks in Portland. Dr. Kelly will present results from the CAPS-5, PCL-5, Mini, as well as BDI. Now I'm going to pass it over to Dr. Zaccari.
Thanks, Terri. Morning, everybody. Well, it's morning on the West Coast. Here we have our first poll question. So this is a 2-part question for our audience members who work in the VA system. In the first question, it asks if your VA is offering yoga to veterans, and the options there are yes, no, or I don't know. And then the second part of the question asks if yes, your VA is offering yoga for veterans, for what purpose is it? Which of these clinical conditions is it offered for? And you can check all that apply there.
Okay,
so
that
just a
poll
few
is currently
minutes.
open. Yeah, the poll is currently open, and I see the results coming in, and many people are responding very quickly here. As soon as it slows down, I will go ahead and share the results with everybody. And it is starting to slow down right now, so I'll go ahead and close that poll. And the poll results, I'm going to share that poll results. And what I see is 65% said VA is offering yoga to veterans, and 15% say no. And if yes, what purpose or clinical? I see A, whole health, 50%. B, general wellness, we have 38%, 25% for PTSD, 33% for chronic pain, and 8% for other. And some of the responses we have in other, chair yoga for those with spinal cord injury, wheelchair bound, and other was offering trauma sensitive yoga prior to CO. Okay, back to you.
I just want to say those results are absolutely thrilling. I love seeing yoga grow in the VA system and just in healthcare in general. Okay, so here we've presented a side-by-side comparison of our experimental intervention, which was trauma center, trauma sensitive yoga, or TCTSY, and our control condition cognitive processing therapy, or CPT. We've presented some of the main features of each of these interventions as a means of seeing their similarities and differences side by side. So they're quite different approaches, though they do have some similar features in their structure that you can see here. The selected dose or number of sessions that was used for each intervention is based on the protocol for each. So TCTSY and CPT groups were co-facilitated in order to allow for one facilitator to address any urgent needs that a participant may have had while in session, so without having to interrupt other participants' engagement in that session. So for example, to attend to any dissociative responses or trigger responses that might interfere with a participant's attention or sense of safety. The most notable difference is that TCTSY is a movement-based therapy with very little talking at all other than the facilitator's cues for yoga practice. And conversely, CPT is a completely talk-based therapy which focuses on cognitions and restructuring thoughts. I'm going to assume that most of the audience might have some familiarity with CPT. In short, it's a CBT-based talk therapy, and the interventions focus on identifying cognitive distortions that cause PTSD to persist and to restructure those distortions while engaging a wider perspective that facilitates improved overall functioning and trauma recovery. And then one last detail to note before I describe TCTSY in more detail is that we define completion for TCTSY as attending 7 of 10 sessions and completion for CPT as attending 9 of 12 sessions. And those cutoffs were based on existing empirical literature. Presented here are some of the finer details about our experimental intervention, TCTSY, or Trauma Center Trauma Sensitive Yoga. Yoga practice focuses on one's embodied corporal experiences. So this made it a very natural fit for some of the defining features of our study sample. Women who had experienced violations to their physical self and well-being through their histories of sexual trauma, complex trauma, as well as sleep and pain issues. It's important to note that not all yoga is the same. TCTSY is a very specific clinical intervention that was developed for PTSD. Specifically, it was developed for women with histories of sexual trauma. TCTSY is not the same as other trauma-informed yogas or yoga for wellness, relaxation, or overall well-being, similar to what is being used in many VA whole health programs. TCTSY is also not a clinical intervention for pain. So it's a very specific protocol that was developed by David Emerson and Bessel van der Kolk for women with sexual trauma. The practice is based on yoga forms, neuroscience, trauma theory, and attachment theory. On the left hand of the slide are the therapeutic themes and goals of TCTSY, which you can see dovetail very nicely with the theories of how it's proposed to work, which are presented on the right. And the themes and theoretical underpinnings could be organized into 3 main buckets per se. So first, TCTSY seeks to facilitate or cultivate one's interoceptive abilities, so the perception of sensations from inside the body, like heart rate, breathing, and so on. Second, it enhances choice and control by using a language of invitation rather than instruction. So a facilitator might use language like, I invite everyone to take a comfortable seat on their mat, or feel free to stand or lay down if that's more comfortable for you today. Eyes can be opened or closed, and so on. So by giving options there and inviting participants, it allows them to choose their actions following those invitations and to develop a sense of control through that. Lastly, TCTSY facilitates taking effective action through yoga participation like I just described. So with this information, you can see how the themes, goals, and theories of how it works all fit together really beautifully. It's theorized to develop areas of the brain which are affiliated with interoception, and through the practice, it's cultivating a sense of safety, leading to support of regulating the central nervous system. And those features made it a perfect match for the way yoga is thought to affect the autonomic nervous system, which Dr. Kelly has published on previously. And here we have our next poll question. Again, for our audience members who are VA employees, there are 2 questions again. If your site is using any type of yoga for PTSD, answer options there are yes, no, or I don't know. And then the second question asks if your site is using trauma sensitive yoga, and the answer options are the same there, yes, no, or I don't know.
Okay, so I have the first part of that poll question open, and it's starting to pick up a little bit here. For the attendees, please make sure that you click submit when you answer your poll questions, and it is slowing down, so I'm about to close that poll and share the responses with everybody. And what I see is 28% say yes, and 17% say no, 36% say I don't know. And I am going to go ahead and open the second part of that poll. And again, your answers are yes, no, or I don't know. And the responses are coming in. And when it slows down, I will close that poll. Let's just give it a few more seconds. Okay, it's starting to slow down, so I'm going to go ahead and close that poll and share the poll results. And apply that. And what I see is 39% say yes, 14% say no, and 42% say I don't know for part 2. Thank you.
Thanks, Maria. I hope everybody who responded, I don't know, I hope this presentation prompts you to look into it. It's exciting to see it growing in the VA. All right, so here we have presented the adaptations that were made for COVID. So this is our COVID pivot. Likely many of the research presentations you've attended lately have a slide like this or have verbalized this information at some point in the presentation. This slide presents the categories of adaptations that we made after the onset of the COVID-19 pandemic in the United States. So our Atlanta site, as Terri had mentioned, had completed 8 cohorts of the study and enrolled a 9th cohort prior to the social distancing restrictions that were enforced at VA facilities nationally. And at the Portland site, we had only screened and enrolled 7 people once those restrictions were enforced, and we pivoted to our virtual adaptation. So as I mentioned, this caused us to have to very swiftly adapt all of our methods of the study in order to allow it to continue while adhering to the social distancing guidelines. So the modifications were very complicated, but I'll try to be very concise here. With regard to informed consent and enrolling participants, we use encrypted email, hard copy mail, and drive-through drop-off to facilitate the consent and enrollment processes. We conducted informed consent by phone or video teleconferencing. For assessment and data collection, we used phone and video teleconferencing to administer diagnostic interviews. We used encrypted email to send links for REDCap, which allowed for real-time data entry of the self-report instruments to be completed by participants, which was the closest proxy we could get to filling out those surveys in person. And then we mailed or offered drive-through pickup of data collection kits to facilitate collection of psychophysiological data, which we guided participants to do from their own homes using video teleconferencing or phone. So that was a pretty significant shift. Collecting ECGs and blood samples, specimens, and heart rate variability ideally would be done in person, but we had adapted them so that they could be done at home by the participants. This was also part of the reason why Portland didn't include the dark startle response and some of the other measures that were in person and collected psychophysiological data. So they were provided postage as well to mail the kits and data back, or they were offered to drive through and drop off the data kits. Both yoga and CPT groups were offered virtually, much like everything we do nowadays. I don't think I need to explain too much what that's like, since we all currently live in a virtual world for most things that are done in a group. I'll note that we did add a third staff member to support the group facilitators, and that third staff member provided technology support for any features or issues that participants were confused about or occasionally experienced difficulties with. Managing suicidal ideation when using virtual mental health interventions required having a responsible clinician available during times of data collection and intervention sessions, who was versed in assessing risk and connecting with local 911 or emergency services in the case of imminent risk. We wrote a special SOP to address engaging that clinician who could then contact the local emergency services to assist with hospitalization if that was needed. And luckily, assessment of suicidal ideation did come up, but we never had to hospitalize. While the adaptations allowed for the successful completion of our study, they will be limits to the data analyses and the ability to aggregate the data, since the methodology of the first 8 cohorts in Atlanta differed from the 9th cohort in Atlanta, which was like a hybrid in-person and then virtual, and the cohort that was run in Portland, which was completely virtual. And that's my spiel. I'll go ahead and hand it back to Dr. Kelly to share the results.
Thank you so much, Belle. So, okay, I'm going to aim to present all of these results and my discussion in about 20 minutes. I'm really hoping to leave time for questions. I'll try not to get mired in the details, though that is my inclination. But I am always happy to answer any questions or reach out to me if you want more detail about our results that we're presenting here. What I want to do is create a picture for you of both our sample, sort of who are we talking about here, and then the outcome measures. So in total, we consented 201 women, but for the purpose of analysis, we're using an intent to treat sample of 103 in Atlanta and 28 in Portland. So this means we are including women who consented, completed screening and baseline data collection, and were randomized to one of the 2 interventions, whether they attended the intervention sessions or not. Atlanta was the primary site for the study. When we're looking at the demographics across both sites, we see that age was remarkably similar and consistent with veteran samples. Our total sample was highly educated, with more than 80% having at least some college. Employment patterns across both sites were similar. There are 2 key demographic differences in our study sample between Atlanta and Portland that are important to highlight, even though the outcome results I'm presenting today are from the Atlanta cohort only. These are particularly important as we think about the potential for implementing TCTSY in the VA and how, one VA is one VA and one sample is one sample. So drawing your attention to the left side of the slide, 91% of the Atlanta cohort is African American and 1% white. In contrast, in Portland, 86% identified as white and 7% as African American. So these numbers are consistent with the VA populations in these 2 sites, but the predominantly African American sample in Atlanta is very unusual for studies of yoga, even those within the VA. And so that's a particular strength of this study. In all, the combined sample is still nearly 3/4 African American. The second important difference in the 2 cohorts is income, with 57% of the Atlanta sample self-reporting a monthly household income of $2,000 or more, and versus 82% in Portland. I'll circle back to these differences at the end, if I can, when I describe additional data collection that we've done with our sample. So from here on, the results I'm presenting include the data from the Atlanta cohort only. So at baseline, the women in this study really had what I would consider high symptom severity that far exceeded clinical thresholds for both PTSD and depression. The PCL-5, that's the middle graph on the left, is a self-report measure of PTSD symptom severity and has a clinical cutoff in a range of 31 to 33. The mean PCL score at baseline in our sample was just over 50. The CAPS-5, which is considered the gold standard because it's a clinician-administered interview to establish a PTSD diagnosis and severity, doesn't have a clinical cutoff per se because it's based on specific diagnostic criteria. But by my math, 14 is the lowest score that could indicate PTSD, and our sample had a mean of over 35 at baseline. So together, these data really indicate moderate to severe PTSD at baseline. We included the Beck Depression Inventory to assess depression symptom severity, given that PTSD and depression are often comorbid. Depression wasn't an inclusion criterion in this study, and I point that out because what we found at baseline is that half of our sample had severe depression symptoms, and an additional third had moderate depression severity, and only 5 had no or minimal symptoms, 5%. A recent VA study that I came across last night, honestly, reported that veterans with racial or ethnic minority status are 12.5 times more likely to have depression comorbid with PTSD than to have PTSD alone. We'll need to do a deeper dive on these data in our study at a later point. But this high rate of comorbid depression in our sample may explain our data related to suicidality at baseline. So in Atlanta, at baseline, nearly 1 in 3 women reported suicidal thoughts in the previous month. Of those, let's see, over 55% had moderate to high sort of ratings of the intensity of those thoughts. Nearly 1/4 of our women had attempted suicide in their lifetime. I point these results out for a few reasons. One is to convey our approach to inclusion in this study. This was not a pragmatic trial by design, but certainly was an approach. We had as minimal exclusion criteria as possible. And so clearly, women with suicidality were included in the study. The only exclusion was if they were in immediate harm and needed immediate danger or risk and needed to be provided intensive services. This was us trying to get as close to the actual clinical population as possible while still running a clinical trial. So let me jump into the results. And this is where a picture speaks 1,000 words. So starting with the PCL, so again, this is self-report. In each of these graphs coming up, TCTSY is on the left and in, let's call that salmon, and CPT is in blue. What I love about these graphs is that you see just a really nice decline over time from baseline to 3 months post-intervention. And so clearly, time is significant. Both groups significantly decreased on their PTSD symptom severity over time, but there's no group effect, meaning at the end of the study by 3 months, there was no statistical difference between the groups. Another way to look at the PCL data are change scores. And so while the graph I just showed you reflected the mean of each group, this shows you how individuals did. So when we separate it out this way, we're able to see that both declined, but the trajectory was different. So in TCTSY, people improved by midpoint, which was literally after 5 or less sessions of yoga. The CPT group sort of stayed pretty much without much change at midpoint and then had really much more dramatic improvements. This is something that we see in clinical practice. What we did not see here was a worsening of symptoms, which we often hear sort of anecdotally, which is one of the reasons that people often drop out of CPT. Looking at the CAPS, this is again the mean total severity score over time. So they started in roughly the same place. dropped really significantly by midpoint. And then the TCSY group sort of leveled off after 2 weeks post-intervention, while the CPT group continued to improve. CAPS can also be used to establish a PTSD diagnosis. And this is, allow me some leeway here because for symptoms, for a PTSD diagnosis, we really need to look at symptoms over the previous month, and our midpoints were at 2 weeks, not, past 2 weeks, not past month. Nonetheless, what we see is even at the end of the study, at 2 weeks post-intervention and 3 months post-intervention, not a small number of participants still met the diagnostic criteria for PTSD. In yoga, it was around, it was just a little bit over 40%, and the CPT group was at 52, I think. So the CPT findings are similar to what we see in the literature. The yoga group, also consistent with what we see in yoga literature. But the improvement is remarkable, but the persistence of symptoms is not to be ignored here. I'm going to shift a little bit and just talk about depression. I told you that was not an outcome at the outset, but what we found, because we tracked depression symptoms over time, was that both interventions did improve depression symptom severity. We also see that in the TCTSY group, a similar trajectory of dramatic improvement in the first 5 weeks, continued improvement, and then a leveling off after the intervention ended. In CPT, there seems to be a slower initial response, but then really a more robust and sustained continued improvement. So that's important to note. Again, looking at change scores, which looks at, for individuals, how did they do, as opposed to just the whole group. On average, individuals improved on the BDI by about 8 points in the TSY group, and closer to 9 in CPT. The positive, the direction of this is fantastic. The trajectories are worth noting. And again, it's worth noting that neither of these interventions was designed to treat depression. So we'll consider that a win. Or the effect of all kinds of other things, which is a talk for another day. Okay, let me talk a little bit about study attrition and treatment completion. And this is where it becomes really important. So the slides that I've shown illustrate that the effectiveness, and I am calling it effectiveness and not efficacy, because we were so grounded in a clinical setting. By the end point, at 3 months follow-up, there were no significant differences between groups, and both groups had improved with clinically meaningful change. What's important here to know, though, is in the study, and this I think reflects at least our experience in Atlanta and what I read in the literature in terms of clinical treatment for PTSD. In our study, we actually screened 466 women for the study. Of those, we consented 152. Of those, we randomized only 103. And so we had 32% attrition. So a third of people dropped out between being screened for the study and coming back for a more detailed assessment and to be randomized. And then after randomization, so completed baseline assessment, and were randomized to either yoga or CPT, prior to the first intervention session, 10% dropped out from TCTSY and 20% dropped out for CPT. So you see how the numbers drop. On a positive note, for treatment completion in Atlanta, for For TCTSY, treatment completion was 60%, which is in the world of PTSD treatment, robust, not what any of us would like it to be, but robust. And for CPT, and these numbers reflect a completion number of 8 out of 12 sessions, the completion was 38%. So what this tells me is that treatment only works if you complete it. And what I see here, my interpretation of these numbers is that CPT works for some people, yoga works for others, some might work for both. We have a lot of unanswered questions. And it's also important to note that with this analysis, when we talk about treatment completion, this is obvious, but I'll state it, this includes only the people who hung in there, right? So the improvements that we see in the slides that I already showed you reflect people who hung in there. I want to just clarify this treatment completion number for CPT, because this is something that came up and it's a function of running a study for 5 years. The literature when we started the study supported 9 out of 12 sessions, or that was my understanding, and we have subsequently changed our math on this to define treatment completion for CPT as 8 out of 12 sessions, really consistent with the literature I've learned more about. Okay. I blasted through those results because I want time for questions and discussion. Let me highlight a few of the limitations. Every study has limitations, but the take homes I think that are really important here are that attrition in the study was high, both in terms of study procedures and intervention sessions, meaning dropout was high. And these numbers are pretty similar to what we see in clinical practice. Neither intervention or neither intervention was effective for everyone. And importantly, the last Atlanta cohort and the one Portland cohort occurred during the first few months of the COVID. Oh my God, it wasn't COVID-10, it was COVID-19 pandemic. And the context was major. At that same time, we had the political election, the presidential election, we had the racial justice movement, and unprecedented climate change events. And I'll draw your attention again to the study sites involved here. We are in Atlanta and Portland, Oregon, where all of those phenomena were playing out largely in public discourse and in people's experiences. Because of that, we have added an additional sort of set of data collection. 2020 and 2021 really became a natural stress test for skills learning and how people cope in the face of trauma. And so in late spring of 2021, we received an extension to collect additional data in both sites. And what we're doing is examining the intersecting impacts of the COVID-19 pandemic, the racial and political discord in the US in 2020 and 2021 on our participants in both sites, really in multiple dimensions of their lives, including, COVID infection rates, how many people do they know who died from COVID, how were, economic impact, all of the things that we were also aware of, particularly early on in the pandemic. We're also looking at their coping strategies, resilience, etc., social support, all of that, as well as their mental and physical health. This is a quantitative and qualitative data collection. What we will also be able to do is describe the trajectory of psychological symptoms in our study sample for some people as many as 4 years out from their participation in the study. So we're done with the quantitative collection. We're still collecting more qualitative data because it's so fascinating. So setting that separate phase 2 aside, in terms of the aims of this study and talking about TCTSY as a clinical intervention for PTSD, and how did we do? How did this study, what did it tell us? Well, what we saw is that TCTSY resulted in really equivalent improvement in PTSD symptoms as CPT at 3 months post-intervention. TCTSY had a 22% higher treatment completion rate than CPT. And in the VA, this is something we care about. Getting people through treatment and improving is our goal. And with PTSD, for lots of obvious and then some less obvious reasons, that's a big challenge. The symptom trajectories varied. And it's important to note these. It also may explain the higher completion rate, because for TCTSY, they had earlier symptom improvement than CPT, which may have been a motivator to keep people in the study. And then they leveled off. CPT had a slower symptom improvement, but it really did continue without leveling off post-intervention. And then co-occurring depression symptoms really improved significantly in both groups, and that's something that we'll need to look at. So implications, I want to hear from folks about what you think the implications are, but what I'll assert is that TCTSY is an alternative to cognitively based, trauma-focused treatment. Neither TCTSY or CPT or the other gold standard treatments are sufficient for all individuals, but having an additional option provides veterans a choice in treatment. It may also be that TCTSY would be effective as a precursor, that's my timer, or an adjunct to CPT. And so we need to look further at that. Anecdotally, participants in our study said, well, why can't we do both? Or one and then the other? And so that's something for us to pursue. In terms of this work, an implementation science study is absolutely necessary to determine how to scale up TCTSY as an intervention within the VA. I was beyond excited to see the poll that, at least among the attendees, 39% reported that TCTSY is being used in your VA. And so y'all, please let me know who you are. I know Dave Emerson and Jennifer Turner and lots of other TCTSY folks are on this call, and we know of a few sites that are using this, but I don't know of many, so please be in touch with me. And with that, I will say thank you, and I will turn it over to Allison.
Great. Thank you, Dr. Kelly. Hopefully you all can hear me. It took a minute to get in this morning, but if nothing else, my yoga has taught me to take my deep breaths and to have patience and knowing that it will work out. So thanks again for your presentation. That was fantastic. And I know whole health was mentioned in the presentation, but just a brief couple words about that for the group who might not be as familiar. So when talking about yoga in the VA, it is really important to understand this larger healthcare transformation that's currently underway in VA and is very exciting. So this is our whole health system, which is inclusive of conventional clinical treatment and prevention, self-care strategies, and complementary and integrative health approaches. This approach shifts from focusing on episodic care to working with veterans really early on and throughout their lives, engaging and empowering them to take charge of their life and health. And then again, as I mentioned, within this model, there's an emphasis on self-care and conventional care, but also complementary and integrative health, including yoga. And yoga is actually one of the approaches that are covered under the medical benefits package and should be made available across the system. In addition to all that, veterans develop a personal health plan with their care team and often are assigned to work with a health coach if they're interested to help them explore their mission, aspiration, and purpose, or like we call their map to work through their goals. So the provision of yoga in healthcare settings, it is really exciting to see the growth in VA, but it's still relatively new in the US healthcare system, including VA, and there's still a lot of work that we're doing nationally help support the infrastructure to implement yoga. So for example, development of position descriptions and minimum standards, also tracking and coding mechanisms so we can be able to track the growth of yoga and see where the gaps still are. So you can see from the survey on this call, out of the attendees, a great number of you all reported having some form of yoga or maybe some trauma-informed yoga at your sites. And when we did a data poll in fiscal year 2021, it looked like about 80% of our parent facilities were offering at least some yoga within that year, which is really exciting. And we do know that in the community, women are often higher users of complementary and integrative health and yoga. And we know we've got a good number of women veterans who are accessing those services within the VA as well. So thanks again. I want to save the rest of the time for the questions and discussion. I saw a bunch coming in through the Q&A. So Ronnie, I'll hand it over to you and your team to help facilitate that. Thank you.
Thanks so much, Allison. Really always appreciate your reflections. And thank you to our presenters. That was a very engaging talk, and the three of you did such a nice job going back and forth. And we have a lot of questions. In case we do not get through all of them, I want to encourage attendees to contact the presenters with your questions. Their emails are here, and because we need to end promptly at 1 p.m. So, Dr. Kelly, there are lots of compliments in the chat, thanking you for the diversity of your samples, and what a great template you're providing for providing a PTSD program for women veterans. So I'm just going to get to some clarifying questions. One is, did you exclude any participants that had comorbidities other than depression, such as psychosis or bipolar disorder?
Oh, what a fantastic question. Yes, only if the, particularly people with psychosis, only if it was at a level of severity that would have precluded them from being able to meaningfully engage with either intervention. So, for example, the psychosis, the symptoms that people sometimes have with PTSD and major depression with some psychosis, hearing some voices, hearing their name being called, that was not sufficient to be excluded. It really only was if someone was so psychotic that they would not be able to engage.
And that's so great, because that's different from a lot of efficacy trials. So that's really wonderful to hear. Another clarifying question was the yoga intervention done at a VA facility or a local yoga studio offsite?
Great question. At the VA facility, and the feedback from many participants is that they would have much preferred it be offsite.
From a transportation perspective, or?
Oh, transportation, somewhat, but more an environment. Women veterans and any veteran who experienced MST, but particularly women veterans, often find coming to the very male-dominated environment of the VA a trigger in and of itself. And so that made it challenging for some people to engage with either intervention.
Yes. Okay. Got it. So I've just lost this question. I'm looking for it again. Do you have any thoughts about CPT training? Oh, my chat keeps jumping around. Sorry. About CPT training clients to become their own therapists, such as challenging negative thoughts. Could this potentially lead to the further deepening of improvement in that arm?
That is a question I will bounce to Dr. Zaccari, our resident CPT expert.
Oh, great. Thank you.
Hi, thanks. So yeah, I do think that that's, that is kind of built into the protocol of CPT, and that is the idea of CPT is that you learn the techniques so that you can do, be your own therapist and apply those techniques without the support of weekly therapy. So since it's already kind of part of the protocol and built into the treatment model, I assume that, we did measure fidelity to the treatment protocol. So I'm going to trust that, that was conveyed to the participants. So I don't know necessarily that there would, I imagine that you could do like a booster session or modify the protocol to really like point out that sort of expectation of the treatment, but I don't know that it would change the results very much because, like I said, it's already kind of built into the CPT protocol that you're teaching people how to challenge their own distortions. And I want to make sure that I'm understanding that question right. So if not, whoever asked it can email me or ask a clarifying question.
Thank you, Dr. Zaccari. I'm going to bounce around with questions just because I know that we have some other experts on trauma, sensitive yoga here too. So I want to get to some of those questions. Have you compared your TCTSY program with other similar programs being used in other countries? And I don't know.
I'm not sure how to answer that. I mean, certainly, I'm aware of the other studies that have been done. I think a study was just published or publicized by JRI that was done in Mexico. So I haven't done that yet. I did look to see what our baseline, the characteristics of our sample here in the VA, how it compared, for example, to the first study that was published on TCTSY in Boston, the PTSD scores were similar, but I think the cumulative trauma and some other relevant stressors are higher in this group. It's a different population.
And I just want to encourage Dave Emerson or Jennifer Turner or anyone, you are also welcome to put things related to that question. If you know of any potential resources or answers, you could put that right in the Q&A as well.
Yes, please do. This is why they're there.
And another question related to TCTSY is there any potential role of community support in the TCTSY group, especially if the yoga sessions are in a group setting? Although perhaps, sorry, my chat is jumping around. So I guess I'll just leave it at that. Do you have any suggestions about TCTSY community support? Especially, I guess, if things are being done virtually, how can you support people?
Okay. I was interpreting the question a little differently, so let me come at it from a few angles. What we attempted to do with the TCTSY group, the whole time it was face-to-face in a group setting, was really encourage them, for example, not to engage with each other in the waiting room, for example. So we worked very hard to have it not be a proxy for social support, to dilute the effect of the actual intervention. We really emphasized this is your time and this is your time to go inside, as opposed to sort of having the buffering effect of a group. So that's one way I would answer that question. We are still looking at the data, particularly that we have from the virtual group in terms of facilitator feedback and participant feedback, because of course it's so different to do it virtually, and it was live, but it was virtual. And so there were reports of still being able to feel engaged, and in fact, their treatment completion in Portland was significantly higher than in Atlanta in that one cohort. So I hope I've answered that question somewhat, but please reach out to me for further discussion if necessary.
Thank you. Another TSY question is, did trauma-sensitive yoga intervention, did it incorporate all 8 limbs of traditional Hatha yoga, or was it primarily asana-based? This person is curious about process components most associated with change.
Dave and Jennifer, would you like to put something in the chat?
All right, we'll leave it to them, and maybe we can also give some. Maybe there's something that we can put in the Q&A about where people can go to learn more.
Oh yes, please. So trauma sensitive yoga. Let's see. Let me find it.
That's all right.
Or Dave or Jennifer can pop that in the chat as well. Right to your website, please.
And then another person asks about trauma sensitive yoga. Does this person says, my understanding is that TCTSY does not include meditation. Was meditation used in this study?
That's an interesting question. And I, again, would like to defer to the TCTSY facilitators. I could have offered a disclaimer up front that, one, I'm not a veteran, And two, I am not a yoga teacher or a TCTSY facilitator.
Great. Yeah, no, that's fine. I mean, people are just asking about like sort of like what are the pros and cons of including, you know, different parts of yoga practice for this population. So I love to see that there's so much interest in trauma, the trauma center, trauma sensitive yoga. And unfortunately, it's 1 o'clock, and I know that we did not get to all the questions, you know, and I apologize that I couldn't get to them, but please do contact the presenters here. And thank you, Dr. Kelly, Ms. Haywood, Dr. Zaccari, Allison Whitehead, and the great CIDR team for helping us with this presentation. We will see you in January with a presentation from Dr. Justine Hyde, who will be presenting on different tele-CIH approaches used in whole health. So thank you, everyone, for your participation and attendance today.
I also want to thank the presenters for coming on board. I will send you all the questions that were asked for today, so you will have them.
Thank you.
And I also want to ask the audience, and thank you for joining us for today's cyber seminar. When I close the meeting, you'll be prompted with the survey form. Please take a few minutes to fill that out. We really do count and appreciate your feedback. Have a great day.